So I'm going to be talking about expanded hemodialysis, or HDX. This is dialysis in evolution and how dialysis is evolving to meet the needs of our elderly population throughout the different countries in the world. So as we all know, our bread and butter is 3 times a week hemodialysis, around 4 hours per each session. Water quality has to be optimized. We can use either ultra pure water or at least a water which has been treated by an RO system. HDXS is preferably an AV fistula or an AV graft. And then we look at all the clinical outcome monitoring of KTOV, the different middle molecules, electrolytes, infectious diseases, and so forth. I understand in Sri Lanka as well, most of it is single use, as is in Singapore. And then the next question would be, what do we do from this point onwards? Is this enough? Are the morbidity and mortality rates acceptable in your dialysis centers? What are some of the technologies that can be adopted to improve this? Shall we offer hemodiafiltration or HDF? Should we use different types of dialyzers? Or is any additional testing and monitoring needed? And with all resource-constrained environments, cost is a major issue. Then procuring expensive machines like HDF machines. Additional training is required both for nephrologists and nurses and the technicians. And so we can do more, but how do we also manage the cost of all of this? So in comes in this new kind of a concept which is called expanded hemodialysis. You will be hearing about this in different international conferences. It is also called HDX. And it is something that we just use a different hemodialysis membrane. And some of the things that I will go over these membranes are the pore size, how it removes the different toxins, improve clearance, compatibility, especially biocompatibility, and what clinical benefits does it have. And then some of the other terminologies that you may hear regarding super high flux membranes or HDX is medium cutoff, high cutoff, and sharp cutoff. So I will go over all of these as well. So I'm not here to promote any kind of dialysis vendor or any kind of membrane, but from a Singapore perspective, majority of our outpatient dialysis centers use the NephCon line. And it is a good line to kind of just, from an evidence-based perspective, go over it to see, to illustrate what the different kind of dialyzer membranes are there. So we have all the way from low flux to middle flux to high flux and then super high flux. And super high flux is when you use it, it is called HDX or expanded hemodialysis. We are all familiar with our bread and butter international guidelines, the KDOGI and the KDIGO. And KDOGI says that we should aim for a KTOV of at least 1.2 for our patients. And we achieve this by giving patients about 3 sessions a week, 4 hours each time. The more sessions we do, of course, we approximate our internal or native kidney functions well, and the outcomes are much more superior. But of course, we can't do 7 days of dialysis for every patient. It's cost prohibitive, and we don't have the logistics in any country to do that. So a long time ago, the KDIGO committee convened, and they said that to achieve a 1.2 KTOV, 3 sessions a week with 4 hours each session is approximately okay for them to get a reasonable amount of morbidity and mortality reduction. So to my medical students, I always say that a KTOV of 1.2 is equivalent of actually an eGFR of only 5%. So you're essentially giving these patients a kidney function of only 5% by giving them 3 times a week dialysis, 4 hours each time. So each dialysis, we have to make the best of it to use that time effectively. Our dialysis nurses are very familiar with the membrane cartridge. This is what it looks like. There is a potting which holds the membrane. There's a dialysis port cap. There's a header and a housing and a blood port cap. Most of these membranes are sterilized in a specific manner. For Nipro and the better dialysis membranes, they use dry gamma radiation, and that puts them with a shelf life of 3 years, and it's best for single use. Not all membranes are made the same way, so the best material in the world to make a membrane is this PES, polyether sulfone, of which these Alisio membranes are made of, that we use in Singapore. And super high flux dialyzers are nothing new. They have been there for over 20 years. They were made to reduce this issue of middle molecular clearance, and it was first adopted in Japan by the Japanese Society of Dialysis, and they had different recommendations. So even in the early 80s, the first generation of these super high flux membranes were made, and then they finally were evolved. One of the biggest issues with this earlier membranes was albumin loss. So once you make the pore larger, you do reduce all the bad things that you want to remove from the blood, like phosphate and middle molecules, inflammatory molecules. But at the same time, you lose a little bit of good things as well, like albumin, causing them to have sarcopenia and protein energy malnutrition, especially in patients who are borderline or frail. So to reduce this effect, it was given, the recommendations were that the weekly albumin loss should be less than 12 grams per week. And this is how these super high flux membranes evolved to reach this target. We all know about beta-2 microglobulin. It is on the surface of every single cell in our body. It was actually used as a tumor marker to diagnose certain tumor cells. But in the context of nephrology and dialysis, it's a very good marker for middle molecular clearance. It's expensive to do, so we mostly look at phosphate and other things which are more easily done in our laboratories. But of course, it is one of the best markers to look at for our patients. And when we use low flux membranes in cost restraint settings in the world, many of the nephrologists see these complications. So you have dialysis-related amyloidosis with bone and joint issues, which is illustrated here in both the photographs and also on the radiograms. And patients have a lot of joint issues, pain, carpal tunnel syndrome, and even cardiac issues because of this deposition of beta-2 microglobulin causing this amyloidosis. And in the past, when we only use low flux membranes, this was a very common occurrence. But as we started using middle and high flux membranes, this is hardly ever seen in countries that use high flux membranes. So in Singapore, we have never seen a case of dialysis-related amyloidosis because it's all high flux for maintenance dialysis patients. Not only is it amyloidosis, due to beta-2 microglobulin, it is a very good marker for prognosis or mortality rates in patients. So it is a very good surrogate marker for middle molecular clearance. And as beta-2 microglobulin levels increase in the blood, so does the mortality rate. So in essence, if you can lower the beta-2 microglobulin levels in your patients, their mortality rates reduce significantly. And once again, only high flux membranes and super high flux membranes can reduce beta-2 microglobulins. It is not reduced at all by low flux membranes and very little by middle or medium flux membranes. Another thing that I tell my medical students is that we always look at urea and creatinine. So what is urea and creatinine? They're just byproducts. They're not uremic toxins. They're surrogate markers of uremic toxins. So if a urea level on its own is high, and they've shown that in animal studies, it doesn't cause anything. Creatinine level high in the blood doesn't cause anything. There's surrogate markers for uremic toxins, which give all the signs and symptoms of renal failure in patients. And these uremic toxins have been the cause of the highest reason for mortality and morbidity in our patients, which is cardiovascular disease. So most of our patients die of arrhythmias, heart disease, infections, and cancers. And all of this is because of low clearance of middle molecules and inflammatory markers which cause these issues. And this is a color-coded slide, so you can see various kinds of uremic toxins of various sizes in our blood. And if you look at the red rectangular box, these are markers which are only removed by super high flux membranes. So even when you give patients dialysis by high flux membranes, a lot of these middle molecules are not cleared. And this is where the bulk of your uremic toxins lie, which are causing the cardiovascular disease and mortality in these patients. So it is not surprising that most of our patients, even with the best kind of dialysis in developed countries like Singapore, when they get high flux membranes, their lifespan is about 5 to 10 years at best. So we have to talk about transplantation and other things. And these uremic toxins, as we are all aware, cause a lot of symptoms. The small molecules which are cleared by low flux membranes cause fatigue and weakness and exhaustion. So even when you give these patients a low flux membrane to get dialysis, some of them will feel better. But majority of the middle molecules and the large molecules is what cause them to have morbidity and death. And these are not removed by low flux membranes, they're removed by high flux and super high flux membranes. And this has been extensively documented in various studies and in the literature, in peer-reviewed literature in the nephrology world. And I've just listed a number of these cytokines, interleukins, inflammatory markers, which are only cleared by high flux and super high flux membranes, and which are the main cause of cardiovascular disease in our patients. So the reason why our patients die of heart disease and coronary artery disease is because of plaque rupture. So they get these plaques because they have hypertension, hyperlipidemia, sometimes even diabetes. 2/3 of patients in Singapore are diabetic. And then once these plaques form, the inflammatory markers which are not cleared by dialysis cause a rupture of these plaques, causing acute MIs and death and morbidity. And once again, super high flux membranes are the best to reduce these inflammatory markers in our patients. And if there's any take-home message from my talk today, it is that our patients are not dying of uremia, they're dying of inflammation, which is not adequately controlled by a suboptimal dialysis, even though it may be done 3 times a week, 4 hours each time, just because the heart of the dialysis machine is a membrane. We are using a low flux membrane on a long-term basis, which is not going to remove these middle and large size molecules. So I had the pleasure of going to Japan about a year ago. I visited Maida Hospital, which has over 100 years of experience in doing dialysis. And when I visited their dialysis center, the average age of the dialysis patient was above 90. They just don't die. And I can tell you it's not because they eat sashimi and sushi. It's because they have these super high flux membranes, which are the core of dialysis in Japan. So if you look at the different mortality rates in the world, and I myself was trained in the US, so if you look at US and Europe, they do well, and we approximate these rates in other countries like Singapore, but Japan is way ahead, and not way ahead by just a little margin, by a vast margin. And because Japanese nephrologists don't really speak English that well, only a very, very few of them do, there's a language barrier, and they've not really been publishing in the English side of the literature to show their outcomes. So it was a big eye-opener. And a lot of those patients are doing 4 hours 3 times a week, but they're using super high flux membranes as their base membranes. And that is the reason, that is the only thing that they do differently in Japan, which is giving them an immense amount of mortality and morbidity benefit. So if you look at the mortality rates in Japan, on the right end of this slide, they're much lower than any other country, any other developed country in the world, and that is due to their super high flux or expanded hemodialysis, which they do for the bulk of their patients. We have a system in EU and US of rating our dialysis membranes and how they reduce the middle molecules in the patient's blood. But if you look at the Japanese classification, the super high flux and criteria are equivalent to the high flux in EU and the US. So EU and US have not even looked at membranes which reduce the beta-2 microglobulin to the extent that the Japanese technology has, and they've been doing it for decades. So the 5 categories of beta-2 microglobulin clearance, category 4 and 5, these are the super high flux membranes, and they account for 93.8% of all membranes used in Japan. So more than 90% of patients are on super high flux or expanded hemodialysis in Japan. And this was as of 2013. It has actually even improved by now. So this super high flux membrane, which is giving us this HTX or expanded hemodialysis, is the main cause of these better outcomes. Once again, it is made of this PES membrane, which is a very superior product. It has equalized pore size, so all pores are of equal size, and they have other features like BPA-free and all of that. So I understand there's a lot of cost concern in developing countries and resource-constrained environments, but not all membranes are made the same, is my take-home message for you. And if you look at the polyether sulfone, again, the literature has shown it is one of the best as far as causing morbidity and mortality rates reduction in our patients compared to any other kind of material that some of the cheaper manufacturing countries in the world use to make the dialysis membranes. And this has been tried on hundreds and thousands of patients, and it has been very well documented to reduce mortality and morbidity rates. And even in this PES membranes, the super high flux membrane, of course, gives you the maximum amount of morbidity and mortality benefit compared to even high flux, medium flux, or low flux. So looking at the membrane structure, equalized pore size is very important. So if you look at the left, this is, I've redacted the names of the manufacturers because I don't want to badmouth any manufacturer, but I can tell you that this is from a very reputable manufacturer in the world that we even use in Singapore, but it is of uneven pore size when you look at it under the microscope compared to the Japanese technology, which is all of equalized pore size. So you know exactly what is being filtered and what is being retained in the blood versus different pore sizes which are allowing different levels of ultrafiltration and solute clearance from the blood. And then the good things like albumin and all, there will be pore sizes which will be large enough to let them leak through it, causing more sarcopenia, frailty in our patients, which I can tell you is a major problem in Singapore, as is for many other aging societies in the world. So again, I've redacted the names of these membranes, but this is a Spanish study. It's been published in peer-reviewed journals. It looked at Alisio versus membrane A and membrane B. Membrane A was a super high flux membrane, and membrane B was a HDF, hemodiafiltration membrane. And if you look at it, the Alisio one had sharp cutoff, meaning they knew exactly what was being filtered on both ends of the spectrum, smaller molecules and the larger molecules, and much more superior than any other membrane that is in the market. Even so, for when you compare it with HDF, which is supposed to be a much superior therapy than HD, but just by changing the membrane and not changing the machine or anything else, you can get even more superior filtration by using a super high flux membrane of the right kind versus embarking on HDF. So less albumin leakage and a very tightly controlled pore size to know exactly what you are doing. Another thing that was of interest to me when I looked at these membranes was the smooth surface. So not all surfaces are created the same under the microscope. And when you look at these smooth surfaces, they cause less hemolysis. So when I compared my notes with Japanese nephrologists, we use 100 milligrams of Venofer or IV iron in Singapore. We even have now 500 milligrams of Monofer and Ferinject and all. The actual dosage of IV iron in Japan is 25 milligrams, and they hardly use it because there's hardly any hemolysis caused by the membrane of the dialyzer. So they have very little usage of Recamone, very little usage of IV Venofer. So if you look at cost, at least from a Singapore perspective, it is just $2 more for this super high flux membrane versus the amount of hundreds of dollars that we save on Recamone and IV iron and infusions and blood transfusions and hospitalizations. It is very, very cost effective. And that is what the Japanese have noticed, that their overall cost for treating a dialysis patient is much, much lower compared to any other developed country. And in the interest of time, I'm not going to go into this medium cutoff of super high flux membranes, but that basically means that they have come to that sweet spot of allowing enough of the middle molecules to clear and not the albumin side. So overall, these membranes cause excellent solute removal, excellent removal of middle molecules, low albumin leakage, and that is where all these middle molecules which are causing inflammation are removed from your blood, causing you to have excellent morbidity and mortality reductions. And once again, this has been very well documented in literature. Some of the studies I've illustrated here. This was another study looking at beta-2 microglobulin level reductions with these super high flux membranes, which was excellent. And it was very similar to HDF. So I'm going to conclude my talk by just comparing a few notes with HDF. HDF is something which is extremely expensive, even for Singapore. We only have about 5% of patients who are on HDF. And the main reason is middle molecular clearance, inflammation, patients who are frail, have sarcopenia, heart disease, who want that additional clearance. And we found that if we started doing HDF, a lot of these patients were actually ineligible for HDF because they had vascular access issue. They have to have very good blood flows. They had other issues which were causing us not to put them on HDF. Whereas if you just change the cartridge in a normal hemodialysis machine and put in a super high flux membrane, it was actually more superior than HDF without buying these expensive machines, without training the nephrologist to do HDF prescriptions, which are vastly different from HD, and training our nursing colleagues to operate these machines. So overall, just by using a super high flux membrane, it was a very good alternative for HDF. And again, this has been very well documented in the literature. Super high flux membrane are giving us mortality rates of 6% versus low flux membranes of 22%. So it's not just a 1-2% change, it is a marked change. One more interesting thing is that for ICUs that do not have CRRT or CVVH, you can actually do SLED-F by just using a normal HD machine to do SLED, but instead of a normal medium or high flux membrane, you can plug in a super high flux membrane. So SLED-F has been shown in the literature to have as better clearances as CRRT. So again, no CRRT machines needed, you just need a super high flux membrane. And this was illustrated in COVID-19, even in Singapore, where not all of our ICUs have CRRT machines, so you can just use a super high flux membrane with a normal machine and do SLED-F. And the mortality rate reduction, even in COVID-19 patients, was as good as using CRRT in these patients. So this is not a new technology. There are more than 500,000 super high flux membranes used in Japan for over 10 years, giving us these excellent morbidity and mortality advantages. So with that, I will end my talk. Thank you so much.